Imagine a magnificent horse, picture of power, grace, thundering across a field. Now, picture that same animal suddenly brought to its knees, writhing in what looks like just, well, terrible pain from maybe a simple tummy ache. But here's the stark reality. This isn't just any digestive upset. It's a rapidly progressive, often fatal condition. It can turn deadly in just hours. Welcome to the deep dive. Today we're plunging into a really critical, time-sensitive topic in animal health. Equine gastric dilation and distension. We've compiled a stack of specialist standard source material for you, everything from clinical notes to detailed study guides. Our mission, to give you a clear, concise, and thorough understanding of why this condition is so uniquely dangerous for horses, how it shows up, and the rapid, often life-saving actions required. Think of it as your shortcut to being really well-informed, complete with some surprising facts and practical insights, too.
It really is a race against time. And what often surprises people, I think, is how the horse's own design, their basic anatomy, actually makes them incredibly vulnerable here. It's a huge danger. And as we'll get into, there's one particular sign, the cardinal sign vets look for, that isn't just diagnostic. It's often the key to saving the horse's life.
Okay, with that really stark image of danger in mind, let's break down the core mechanics. What's happening inside the horse when we talk about gastric dilation? What exactly are these terms?
Right, so gastric dilation, that's when the stomach gets enlarged because there's too much gas or fluid or sometimes even solid stuff accumulating inside. Gastric distension, though, that's more the clinical sign. It's the enlargement you might actually see or feel from the outside. So dilation is the internal process, distension is the outward sign. Does that make sense?
Yeah, internal process, outward sign.
Got it. And it's also really important to know the difference between primary and secondary dilation. Primary means the stomach itself has overloaded, maybe from something the horse ate,
Yeah.
But secondary is actually far more common and often, frankly, more severe. That happens when there's a blockage further down the digestive tract, like in the small intestine. Everything backs up.
It backs up into the stomach. That makes sense. Now, this next point you mentioned, it really sets horses apart and makes this whole thing so dangerous. What is it about their anatomy that creates such a critical vulnerability?
Well, what's truly unique and really problematic for horses is that they essentially can't vomit or regurgitate. They just can't throw up. And this isn't just some quirk. It's because of two main things. First, the angle where the esophagus, the tube from the mouth, enters the stomach, the cardia, is a very sharp angle. And second, there's an incredibly strong muscle, a valve, the cardiac sphincter, right at that entrance.
Ah, okay. So it's like a really effective one-way door.
Exactly. It basically creates a one-way valve. So if the stomach starts to stretch and distend, all that gas and fluid gets trapped. There's nowhere for it to go. And that dramatically increases the risk of the stomach actually rupturing, tearing open. Plus, even if somehow, against the odds, material did manage to reflux back up, there's a huge risk of aspiration pneumonia where that stomach content gets inhaled into the lungs. That's also incredibly dangerous.
So, okay, for an animal as large and powerful as a horse, you'd think maybe they have a massive stomach, right? But you're saying that's not the case.
No, not at all. It's actually genuinely surprising. Their stomach capacity is relatively small, only about 8 to 15 liters. That's roughly 2 to 4 gallons for an adult horse. It's a system designed for continuous grazing, small meals trickling through all the time, not big, infrequent ones.
Wow, 2 to 4 gallons. That seems tiny for a 1,000-pound animal.
It is. And that small capacity, combined with the fact they can't vomit, makes any pressure buildup inside just incredibly dangerous very quickly. As that internal pressure increases, it causes intense, severe pain. That's the colic we see. But the pressure also messes with their circulation. The swollen stomach pushes on the diaphragm. It presses on a major vein, the vena cava, and that reduces blood flow back to the heart, which can rapidly lead to shock.
And locally, what's happening to the stomach wall itself?
Well, the stomach wall itself starts to suffer. It doesn't get enough blood flow that's called ischemia, and the tissue can start to die, necrosis. And ultimately, the thing we fear most, the most fatal complication, is gastric rupture. The stomach wall just tears, usually along the greater curvature, the longer outer edge.
Right. So we understand why the horse is so vulnerable now, the anatomy, the small stomach.
Yeah.
But what actually triggers this? What kicks it off? Let's dive into the causes, maybe starting with those times when the stomach itself is the primary problem.
Okay. Well, the most significant primary cause is something called engorgement colic. Basically, severe overeating. This happens when a horse gets into a huge amount of feed, especially stuff that ferments quickly like grain, really lush pasture, beet pulp, sweet feed, that kind of thing. These feeds can rapidly produce gas as they ferment, and they also swell up with moisture, just overwhelming the stomach's ability to empty normally.
That makes me think of all those, classic barn scenarios. The horse breaks into the feed room or a bin splits open. It sounds like those aren't just stories, they're genuinely high-risk situations.
Absolutely. Those seemingly simple accidents are often exactly how primary dilation starts.
Hmm.
They're not just tales, they're emergencies waiting to happen. Another primary cause, maybe less common but still important, is water issues. Like if a horse hasn't had water for a while, eats a lot of dry feed, and then gets unlimited access to water. That dry feed just rapidly absorbs the water and swells dramatically right there in the stomach.
Ah, okay. So hydration management is key too.
Definitely. And then there are some other less common primary causes. Things like really severe ulcers near the stomach exit, the pylorus causing an outflow blockage, or maybe a gastric impaction from very dry fibrous stuff, or even sometimes primary gastric motility disorders, where the stomach muscles just aren't working right to move things along.
But you said earlier that secondary gastric dilation is actually more common and often more severe. So what's going on in those cases? What's the real root of the problem there?
Right. This is key. The core insight is that you can have this massive stomach problem that isn't actually starting in the stomach. It's a dangerous knock-on effect from a blockage further down the line. So secondary gastric dilation is usually caused by reflex stuff, backing up from an obstruction or a functional paralysis, what we call ileus, of the small intestine.
Okay, ileus means the intestine just isn't moving, right? Like it's shut down.
Exactly, it stopped contracting normally. So if fluid and gas coming from the small intestine can't move forward because there's a physical blockage, or because the intestine has just stopped working, it all refluxes, backs up into the stomach. And since the stomach can't empty it out the normal way or vomit it up, it just distends severely.
So the problem originates downstream, but the life-threatening pressure builds up in the stomach because it's trapped. Can you give some examples of what might cause those downstream blockages?
Sure. Common examples of small intestinal obstructions include things like ileal impactions. That's a bad blockage, usually from compacted feed in the last part of the small intestine. Or more complex, nasty things like an intussusception, where one bit of intestine telescopes inside another. Or a strangulating lipoma, that's a fatty tumor on a stalk that can wrap around the bowel and cut off blood supply. Or even something called epiploic foramen entrapment, where intestine gets stuck in a small, natural opening in the abdomen. Or a volvulus, which is a twist in the intestine itself, all surgical emergencies.
Wow, okay. And what about the ileus, the functional shutdown? What causes that?
ILEs can happen for various reasons, maybe after surgery due to anesthetic drugs, or with severe medical colic conditions. Sometimes significant electrolyte imbalances can trigger it too. So what this all boils down to is, in secondary dilation, the fundamental problem is that stomach contents just cannot get out into the small intestine. That leads to the dangerous, potentially fatal buildup.
This sounds incredibly painful. I mean, just agonizing for the horse. What are the alarming signs? What would an owner or a vet look for if they suspect this is happening?
The number one sign is often severe, acute colic. And I mean severe. This isn't mild discomfort. It's often violent, intractable pain that doesn't respond well to initial painkillers. You'll see specific behaviors, flank watching, turning their head to look at their belly, pawing the ground, maybe trying to roll, stretching out awkwardly, profuse sweating, just really distressed. You might also see or feel abdominal distension, like a visible swelling, especially high up on the left side, in what vets call the left paralumbar fossa.
And you mentioned that cardinal sign earlier. What is that specific critical indicator and why is it so absolutely vital?
Yes, the cardinal sign is profuse nasogastric reflux. This is basically a sudden discharge of large amounts, we're talking liters, often of foul-smelling fluid, maybe mixed with feed material, coming out of the horse's nostrils. It's often triggered when a vet passes a stomach tube, but in really bad cases, it can even happen spontaneously. If you see more than 2 liters refluxing from an adult horse, that's highly significant. It screams gastric distension.
Okay, so large volumes of fluid from the nostrils, that's the big red flag. What other signs might be present?
You'll often see other signs of distress and shock. A really rapid heart rate tachycardic, often over 60, even 80 beats per minute or more. Rapid breathing tachypnea. Their gums, the mucous membranes, might look pale or sometimes dark red, injected. Capillary refill time, how quickly the color returns when you press on the gum, will be slow, indicating poor circulation. Pulses might feel weak. And importantly, when listening with a stethoscope, gut sounds are often absent or very much reduced. Dehydration sets in quickly too, all signs the horse is in serious trouble.
So a vet arrives, sees a horse showing these, frankly, terrifying signs. What is the absolute first, most critical diagnostic and therapeutic step they have to take?
The single most critical and immediate step is passing a nasogastric tube, a stomach tube. This does 2 things at once. It confirms the diagnosis. If you get that large volume of reflux, you know you have severe distension. And crucially, it starts the life-saving treatment. It immediately begins decompressing the stomach by letting all that trapped fluid and gas escape, usually just by gravity, maybe with a gentle siphon. We often also perform stomach lavage. That means carefully pumping maybe 5 to 10 liters of warm water into the stomach through the tube, and then siphoning it back out, repeating that cycle to try and break down and remove any impacted feed material.
That sounds like it needs to be done very carefully, but also very urgently. Are there specific cautions, things the vet needs to be really mindful of during that procedure?
Absolutely. It requires gentle handling. You never force the tube if you meet resistance, because you could damage the esophagus or even potentially the stomach wall. And when doing the lavage, the washing out, you have to avoid putting too much pressure in because, again, a severely distended stomach is fragile and you could potentially cause it to rupture.
Yeah.
So gentle technique is vital.
Okay. Besides the stomach tube, what other diagnostic tools might be used?
Well, a rectal exam is usually done as part of any colic workup. But honestly, for gastric dilation, it's often limited because the stomach is so far forward in the abdomen, you usually can't feel it directly. Abdominal ultrasound, however, can be really useful. It lets us visualize the stomach, see how distended it is, maybe assess the wall thickness, and crucially, it can show if the small intestine is also distended, which points towards that secondary obstructive cause. And then, if gastric rupture is a real concern, we might do an abdominostentesis, a belly tap. We insert a needle into the abdomen to collect fluid. If we find feed particles in that fluid, well, that confirms a rupture. And that's devastating news. Blood work is also important. It helps assess dehydration, checks lactate levels, which indicate shock, looks for electrolyte imbalances caused by all the fluid loss into the stomach and reflux.
The urgency really comes across. So once that diagnosis is clear, maybe confirmed by the reflux, what is the absolute immediate life-saving action?
Emergency decompression. That nasogastric intubation, getting that tube in, and gastric lavage if needed. That is the most critical, immediate, life-saving treatment. No question. It saves lives because it instantly relieves that dangerous pressure, which dramatically reduces the horse's pain. It improves blood flow, helps combat shock, and most importantly, it prevents gastric rupture. That's the #1 goal initially, stop the stomach from tearing.
Okay, so the pressure's off, the immediate crisis is hopefully averted. What about supportive medical care? What else are vets doing to stabilize the horse?
Right. Decompression is step 1. Then comes supportive care. Pain control is obviously huge. We use NSAIDs, non-steroidal anti-inflammatories like Flunix and Miglemin. That helps with pain, but it also has anti-endotoxic effects, which is important because toxins can be released in these severe gut issues. We also use alpha-2 agonists. These are sedatives and strong painkillers like xylazine or ditomidine. They're really useful because they provide deep sedation, great pain relief for that visceral gut pain, and they also relax muscles, which actually helps drainage sometimes by causing the horse to lower its head. Opioids like butorphanol might be added too. But a really important caution here. Pain relief has to be used carefully. You don't want to mask signs that things are getting worse or that surgery might actually be needed. It's a balancing act.
In fluids, I imagine they're losing a lot of fluid into the stomach.
Oh, absolutely. Fluid therapy is crucial. Correcting dehydration and shock is vital. This usually means aggressive intravenous fluids. 5E fluids, things like lactated ringer solution, often starting with rapid boluses, large amounts given quickly to restore circulation.
Okay, so pain relief, fluids. What about getting the gut moving again, especially after it's been under so much stress, or if there was an ileus involved?
Good question. We might use GI motility modulators, drugs, to encourage the gut to start moving again. But, and this is a big but, only after decompression is well underway. And crucially, only if a mechanical obstruction like a twist or blockage has been ruled out or surgically fixed. You never want to stimulate motility if there's still a physical blockage. Examples of these drugs include things like lidocaine given as an IV drip, metoclopramide, or sometimes erythromycin at specific doses. In really severe cases, we might also need anti-endotoxemia therapy, maybe using polymyxin B to bind up bacterial toxins. And one more proactive thing, cryotherapy, icing the feet. We often do this to try and prevent laminitis, which is a really serious, painful hoof complication that can happen secondary to the severe inflammation and potential endotoxemia from these critical gut events.
Laminitis is always a risk with severe colic, isn't it? Okay, so when does it tip over from medical management to needing surgery? It sounds like for some horses, tubing and beds aren't enough.
Exactly. Surgery becomes necessary primarily if the gastric dilation is secondary to a small intestinal obstruction that can't be resolved medically. So the tube might empty the stomach temporarily, but the underlying blockage in the intestine is still there and needs fixing. Or, obviously, if gastric rupture is suspected or confirmed, surgery might be attempted as a sort of Hail Mary, but the prognosis at that point is incredibly grim. After treatment, whether medical or surgical, management involves keeping the horse NPO nil per os, nothing by mouth for several hours at least. Then, a very gradual reintroduction of feed, usually starting with small amounts of soaked hay, something easy to digest. And of course, continuous careful monitoring for any recurrence of pain or complications is absolutely essential during that recovery period.
This all sounds incredibly serious. The treatment intense. What's the grim reality in terms of potential complications, even if the initial treatment works? And what's the horse's overall prognosis?
Yeah, it is grim. The most catastrophic complication, as we've stressed, is gastric rupture. That leads to widespread infection in the abdomen, peritonitis, sepsis, shock, and it's almost invariably fatal. There's very little that can be done at that point. But even short of rupture, there are other significant risks. Aspiration pneumonia from inhaling refluxed material, severe electrolyte and acid-base imbalances from losing all that fluid and stomach acid, which can really throw the horse's whole system out of whack. Laminitis, as we mentioned, triggered by endotoxemia, and even potential damage to the esophagus from the tube itself or the caustic nature of the refluxing.
So even if they survive the initial event, there can be serious follow-on problems. What about the overall outlook? Does it depend on whether it was primary or secondary dilation?
It really does. For primary gastric dilation, the overeating type, if it's caught early and decompressed promptly and thoroughly, the prognosis is generally pretty good. They can often recover well. But for secondary gastric dilation, where there's that underlying intestinal problem, the prognosis is much more guarded. It really depends entirely on what the specific intestinal issue is, impatient twist, entrapment, how quickly surgery happens if it's needed. Some of those intestinal lesions just have a poor prognosis regardless. And as I said, if gastric rupture occurs, the prognosis is extremely grave, almost certainly fatal.
Okay. So to try and bring this all together, what are the absolute core insights from this deep dive into equine gastric dilation and distension that, everyone listening should really take away?
I think the biggest things are recognizing the horse's unique anatomical vulnerability. They can't vomit, their stomach is small, and that makes this condition uniquely dangerous for them. It's a true life-threatening emergency. Secondly, the absolute urgency of immediate action. Time is critical. Getting veterinary help immediately is paramount. And third, the critical role of that nasogastric tube. It's not just a diagnostic tool. It is the primary life-saving therapy. Without it, the outcome is almost certainly tragic. Recognizing those signs, especially the reflux, and acting fast, that's everything.
Yeah. And while this might seem like a very specific, maybe niche veterinary topic, I think understanding it really underscores the vital importance of taking any colic sign in a horse seriously and getting rapid, decisive veterinary care. It also highlights just how crucial careful feed management is, avoiding those situations that could lead to primary engorgement. It's a powerful reminder, isn't it, of how even these incredibly powerful animals have these, hidden vulnerabilities. So maybe the final thought for you to ponder is this. What does this deep dive into equine gastric dilation really teach us about those subtle yet profound vulnerabilities in even the strongest creatures around us? And maybe more importantly, how specialized knowledge combined with swift, informed action can genuinely be the difference between life and death?